This is an overview of an article entitled Prospective Cardiovascular Genetics Evaluation in Spontaneous Coronary Artery Dissection, published in the April 2018 issue of Circulation, Genomic and Precision Medicine. Spontaneous coronary artery dissection, or SCAD, is a rare non-atherosclerotic cause of acute coronary syndromes with a prevalence rate of 0.07% to 1.1%. Arterial dissection is characterized by a hematoma inside the arterial media or between the media and either the adventitia or intima, creating a false lumen that compresses the true lumen. This compression decreases luminal blood flow and can result in myocardial ischemia and even infarction. SCAD typically affects younger women with low rates of known acute coronary syndrome risk factors, average age of 30 to 45 years, with 70% of patients being female, and has been found to play a role in as many as 40% of heart attack cases in women under the age of 50 years. SCAD shares characteristics of traditional genetically triggered arterial diseases, occurring in young patients and often in those without traditional cardiovascular risk factors. Individual case reports and retrospective analyses have described SCAD in genetically triggered vascular conditions such as Marfan syndrome, vascular Ehlers-Danlos syndrome, and Loeys-Dietz syndrome, and occasionally familial cases have been described. In the paper under discussion, the authors aimed to evaluate SCAD patients in cardiovascular genetics clinic in order to determine the role of genetically triggered vascular disease and the utility of prospective genetic testing. In the paper under discussion, the registry consisted of patients who presented with SCAD at Massachusetts General Hospital, were referred by an outside provider, or were self-referred. Of 107 patients with full clinical data, 73 patients were evaluated in the cardiovascular genetics clinic to consider any underlying genetic disorders that might have predisposed to SCAD. Reasons for not undergoing genetic evaluation were diverse and included distance from the hospital, lack of interest, and insurance-based provider restrictions. The 73 evaluated patients were examined for physical features typical of Marfan syndrome, vascular Ehlers-Danlos syndrome, and Loeys-Dietz syndrome, family history of SCAD, aneurysm and dissection, and known connective tissue disorders and associations. Of these 73 patients, 44 patients were deemed appropriate for genetic testing and underwent genetic testing. Some patients declined genetic testing when offered. The most frequently cited concerns were the possible effects on medical and life insurance. Among the 44 patients, 36 patients underwent genetic testing through the genetics clinic, whereas the others had previously undergone genetic testing. Most patients had a negative genetic finding, 12 had variants of uncertain significance, and only 6 patients harbored pathogenic variants. Demographically, the 73 evaluated patients had similar characteristics as the 34 patients who were not evaluated in the genetics clinic. 85% of the evaluated patients were women, with a mean age at first SCAD event of 45 years. The majority of the study group did not exhibit common risk factors for acute coronary syndromes, including hypertension, hyperlipidemia, diabetes, and smoking. The authors found little difference with respect to SCAD presentation between patients who underwent genetic testing and those who did not. The left anterior descending artery, or LAD, was the most common dissection location in both groups, and both ST segment and non-ST segment elevation myocardial infarctions were common presentations. The physical activity levels of patients prior to their SCAD event were nearly identical between groups. Pathogenic variants were found in 8% of the evaluated SCAD patients. 3 patients had pathological mutations in COL3A1, the causative gene in vascular Ehlers-Danlos syndrome, while 1 patient was found to exhibit autosomal dominant polycystic kidney disease with a mutation in PKD1, 1 patient with Loeys-Dietz syndrome with a mutation in SMAD3, and 1 patient with Nail-Patella syndrome with a mutation in LMX1B. Finally, the demographics of patients with positive versus negative gene testing results were similar, with the exception of a younger age at first SCAD event in those who tested positive for pathogenic variants. To summarize, in this series of SCAD patients, approximately 5% were diagnosed with a Mendelian vascular disease. Patients with positive genetic testing were younger on average than patients with negative testing. Arterial fibromuscular dysplasia was not seen in patients with genetically triggered vascular disease. And vascular Ehlers-Danlos syndrome was the most commonly identified Mendelian disorder in this group. In conclusion, the study showed that monogenic vascular disease represents a significant portion of SCAD cases, and that cardiovascular genetics evaluation should be provided and genetic testing considered for patients with SCAD, especially in younger patients.